الله وبركاته. Delayed healing of apical periodontitis lesion after root canal treatment. Report of 2 cases done by Ricucci and others with Franklin Tay. Published in 2026. Apical periodontitis is a host-mediated inflammatory disease caused by microorganisms from the infected root canal system. The biological objective of root canal treatment is to reduce microbial load, prevent reinfection, and allow periapical tissue to heal and regenerate. Healing is assessed using radiographic imaging, which is most commonly periapical radiograph. However, radiographs are two-dimensional and limited in detecting early bone regeneration or mixed tissue healing. A common clinical dilemma occurs when periapical radiolucency persistent after root canal treatment. This is often interpreted as persistent apical periodontitis or treatment failure, leading to non-surgical retreatment or surgical intervention. However, healing is not a binary process. Large lesion may require years for complete bone remodeling, and some lesion heal with fibrous connective tissue or mineralized scar formation rather than normal trabecular bone. So the purpose of this study was to demonstrate that persistent radiolucency after root canal treatment does not always indicate infection or treatment failure. So 2 clinical cases with large preoperative periapical lesion were followed for several years using radiograph and CBCT to illustrate delayed or mixed healing pattern. The first case is a 53 years old male presented for replacement of discolored composite restoration in the maxillary anterior teeth, placed about 20 years earlier and reported no symptoms. Clinical examination revealed discolored class 4 composite restoration on the 4 maxillary incisor with Miller class 1 mobility, and tooth number 9 showed mild percussion sensitivity while periodontal probing depth were normal. Pulp testing showed no response to cold in teeth 7 and 9 and 10, while tooth number 8 responded normally. Radiographically, a well-defined periapical radiolucency measured about 8 mm with apical resorption was associated with tooth number 9. Root canal treatment was performed with hand instrument to size 60, irrigation with 1% sodium hypochlorite with ultrasonic activation. The tooth was treated in 2 visits, and for the follow-up radiograph at 1 and 2 and 3 years showed progressive lesion reduction but persistent radiolucency, although the tooth remained asymptomatic and clinically stable. At 4 years, CBCT was taken for implant planning for other teeth, and this tooth was evaluated, and it was showing still a residual lesion, and apical microsurgery was performed. Histologically revealed uninflamed fibrous connective tissue with irregular mineralization and absence of bacteria, indicating delayed non-infectious healing rather than persistent disease. Second case was a 48-year-old female presented for replacement of defective and discolored restoration tooth number 7, placed about 15 years earlier, and was asymptomatic. Clinical examination showed a discolored class 4 composite restoration, normal periodontal probing depth, and no response to cold test. Periapical radiograph revealed a well-defined periapical radiolucency with measured 11 mm associated with tooth number 7. Root canal treatment was performed in 2 visits with using calcium hydroxide medication, and then followed by definitive composite restoration. Follow-up radiograph for 1, 2, and 4 years showed a progressive reduction of the lesion but incomplete radiographic healing, while the tooth remained asymptomatic with no percussion and tenderness. CBCT demonstrated a residual radiolucency with internal radiopaque island and bone projection, suggesting intralegion mineralization and ongoing bone remodeling. At 7 years follow-up, the radiolucency was smaller but still present, and the patient remained asymptomatic. So no further treatment was indicated and monitoring was recommended. So in conclusion, persistent radiolucency after root canal treatment should not automatically be considered a treatment failure. If the tooth is asymptomatic, properly treated, and the lesion is reduced or stable, then continued monitoring may be more appropriate than retreatment or surgical intervention. Thank you.